The most common question is, should I do Sudoku every day? First of all, I hate Sudoku.
Me too. I never touched it.
I never played any games. Lifestyle is very much of your personality. I very much think that it's about self-respect. I really respect my body. And then I want to really take care of it because, I really want to age successfully. So to me, it's very important as a person. Forget about being a doctor.
On today's episode of Aikafa podcast, with my guest Dr. Diler Acar, we discuss the rise of Alzheimer's disease among all population, the cause and the alleged cure of it. Dr. Diler is a neurologist trained in Boston, Massachusetts, with over 30 years of experience in the field. She has a strong background in behavioral neurology and neuropsychiatry, having conducted research on dementia and worked extensively at Brigham Women's Hospital and Harvard University Medical School. Her clinical interests include dementia, Alzheimer's disease, learning disabilities, movement disorders, and neuropsychiatry. Fortunately for us, she has returned her home country after decades and currently serves as an attending physician at the American Hospital in Istanbul. Here is something that is fascinating. A huge amount of people who watch this channel frequently are not subscribed. So I want to ask you a quick favor. When you subscribe, it helps us to make the show better, access to the world-leading expert, and ultimately bring you more value. All that I ask is for you to hit the subscribe button, and in return, I promise we will make Aikafa better every day. So, welcome, Dr. Diler Acar. I've been waiting for this conversation for so long, and I've been chasing you. Finally, you came. You know what I want to talk about? It's your specialty. There's this huge increase in Alzheimer's disease around the world. I know the numbers from the US. I'm not sure about Turkey, but now that you're in Turkey, maybe you can give some samplings. It's really ruining people's life, especially the caretakers, what I'm observing. I watched a couple of documentaries about that. People for their spouse are first starting like, yes, I signed up for this because they just see the beginning. But towards the end, they're just like, there was one policeman was explaining, actually in 60 Minutes that I watched, and he was saying like, I'm ready to pull the gun on my head and pull the trigger. So it's not only affecting the person, affects everyone else around. And it seems like we're not going anywhere good. It's not changing. Nothing is changing. And I've been watching many things, and there are a couple of descriptions which made sense to me, saying like, medications are only slowing it down, like some 13%, some 25%. Why would you want to slow down this horrible progress of an illness? So you're going to be longer in that disaster situation than just make it short and just end it. Another thing was like a funny, kind of a jokey description. They say like, Elon Musk comes to you and he says like, I did a wonderful rocket, but it's going to only explode like 20 minutes later than normal. Would you accept it? So that's what people think about the medication. Yet, I saw international work, including yours, whether in the US or in Turkey, that people change. It works. So I'm very confused about that. I have so many other questions about lifestyles and everything, but shall we start? What is dementia? What is Alzheimer's?
Dementia is an umbrella term that we use for any cognitive decline. It could be in any cognitive domains. It could be memory, visuospatial, language, or insight, judgment. And any of these cognitive decline affecting your activities of daily living so that you are no longer independent. So that's the definition of dementia. And then there are subtypes of dementia because dementia and Alzheimer is a very confusing terms for public. I'm so glad I was giving a diagnosis of dementia, but thank God I don't have Alzheimer's disease. So, which is an unbelievable misperception. Yes, you do have dementia, which means most likely that you have Alzheimer's disease because 60 to 70% of dementias are due to Alzheimer's disease. It's the most common dementia, which affects your mainly short-term memory, then progresses and takes over all other cognitive domains. And there are other types of dementias, but the most common is Alzheimer. So they are very much similar is that, yes, if you have Alzheimer's disease, you have dementia. And if you have dementia, you most likely have Alzheimer's disease. So that's how it works in a sense. What do we do? Well, first, I think the proper diagnosis is very important. Many people come in with subjective cognitive complaints. I can't remember anymore. We take a good history, and then we do some laboratory and cognitive tests. We do MRI mainly. It's superior than CT scan. And then we make a diagnosis, is clinical diagnosis. Of course, it's more than 100 years that Alzheimer's disease was first defined. Since then, we made very slow progress, I have to say, because I think it's a very complex disease. This is why we are still scratching our head and saying what causes it, what initiates it, what happens. There is, I think, good understanding right now about the neuropathology of Alzheimer's disease is that it starts with an amyloid accumulation. Then that precedes the tau pathology, just an intracellular tau protein accumulation, which then causes neurodegeneration, which includes synaptic loss, neuroinflammation, and then neuronal health. And it goes that way. So within this cascade, though, the most important question is why amyloid accumulates and what can we do about it?
Can we explain, because our audience may not know what amyloid plaque is?
So the amyloid
it's a
is
very
an abnormal,
big word.
Yes, it's an abnormal protein normally present in the brain, but for some reason, the insoluble form just accumulates in the brain. So that's the best simple way of just describing it. It's extracellular and then affects the cell, which then it starts a cascade of another abnormal protein accumulation, which is tau. Tau is intracellular, and it's a very much of a tangles. It's and then that intracellular effect causes a neighboring effect from inflammation to synaptic loss to, and then the neuronal cell death.
So does it matter where is it in the brain? Because we know that, depending on the area of the brain, that sometimes
Exactly so.
it's the feelings are changing, sometimes memory, sometimes cognition.
So every dementia has its own favorite place to start.
Oh, lovely.
Alzheimer's, it's very interesting, isn't it? Alzheimer's always starts in the entorhinal, just the cortex, then affects, hippocampus, then very much just the progress to affect everywhere else in the brain. There is a more atypical presentation of Alzheimer's disease, what we call posterior cortical atrophy. It's a visual variant. It starts in the occipital lobes, affects occipital parietal pathways. We have a version of executive dysfunction, affects frontal lobes. It all depends on where we are. We have a very distinct dementia called primary progressive aphasia. Affects language. It starts in the language, just locations. So they have their favorite place to start with. But then, because they are neurodegenerative, they progress to affect everywhere in the brain.
Even though technology improved, medicine improved, these neurodegenerative diseases, they don't have a solution, whether MS or any other thing that it starts and there's no stop. It just goes downhill. When I first met you in Nişantaşı, I wasn't so aware of the details of Alzheimer's. I only knew that there is. And obviously people talked about the genetics and you were like, it's not a genetic illness. That's the first, I remember that. Then I started digging in. Numbers that I saw from the US, I don't know in Turkey, but it's between 8 to 14% of the population without the gene can present with Alzheimer's disease. ApoE4, if you have one, what do you call that? One
allele.
Yeah, okay. It is about like, what, 30% or less?
Less, 25%.
But
maybe,
if you have two ApoE4, then you're like high risk.
Much higher risk.
Yeah.
That's it's a risk gene, ApoE. There is, of course, there is the genetic form of Alzheimer's disease, which is autosomal dominant. There are 3 genes that causes the autosomal dominant Alzheimer's disease. It's very rare, but it exists, and ApoE is a risk gene more. There are, of course, almost 100 genes are
Yeah,
identified.
I'm going to come to that because yesterday I had a psychiatrist here and we were talking about a bunch of other stuff. And before we started recording, I was talking about like how there's this approach that things that are crossing blood-brain barriers, such as toxins, heavy metals, illnesses from your mouth, gut bacteria, whatever, everything can go to the brain. Therefore, it would be one of the cause that is creating. And she goes like, well, the toxins are everywhere. So why my sister is having and I don't have it? So that was like, okay, that makes sense too. What's the criteria?
So there are protective genes too.
Okay.
So first of all,
Can we test that?
Well, there's one protective gene, there's a lot of hype about it, but I think just, we're not there yet. But there are some protective factors. First of all, it's our education, isn't it? What we call cognitive reserve. So the more educated you are, the more networks you create, your compensation just, increases. So that's a very important factor. And another important factor is your ApoE type. If you have a type 2, ApoE has 3 types, 2, 3, and 4. 4 increases the risk and reduces the onset of Alzheimer's disease. E2 is protective. If you have it, that's great. And then it's your lifestyle, isn't it? If you don't have any of the cerebrovascular risk factors, the hypertension, hyperlipidemia, diabetes, obesity, metabolic syndrome, these are very important. So it's very multifactorial in a sense. That may explain why your sister has it and you don't have it.
So then let's come to this. Why 8 to 14% of the population? Let's globalize that. Let's imagine that it's everywhere the same. Why is it happening if there's no gene? What's going on? Because it's the biggest fear of the people now.
Age is just the biggest factor. Don't underestimate it. We are living much longer now. I was at a classical music concert last night. They played Mendelssohn and Mahler. Mahler died at age 51 and Mendelssohn died at age of 38. So, 1800s. Think about their just the date of birth. I couldn't believe how young they were.
Yeah.
So we are living much longer. And age is the biggest risk factor, first of all. After age 85, our risk is almost 40%, 30 to 40%, which is just the greatest risk. So we are much more obese. We have much more cerebrovascular risk factors. And I think just the environmental factors, including stress, depression, insomnia, which are very important.
Yeah, they're talking about actually low oxygen capacity to your lungs, even so. You're sleeping
even
or
just
you're
the air pollution. Definitely. These are all very important. This is why we're seeing more and more. And there's also more awareness. If you remember, anneannes and dedes, bunama, but no, they were most likely demented.
I'm wondering, how was it like 30 years ago when you were first in the United States? Because this whole functional medicine approach that you've been now counting all these things, the pollution, the toxins, the packaged food and whatnot, they just started being in the awareness of people after this functional medicine movement started. And then longevity. Before that, nobody cared about anything. Probably there was less of these negative factors, but you went to the United States, you are graduated from Istanbul University Faculty of Medicine, and then you went to Duke, correct?
No, I went to Yale.
Yeah.
But then
you did all
not
the
like
good
New
ones.
Haven.
You didn't like,
and then
that's a spoiled decision, huh? You didn't like New Haven, so I dropped Yale. That's good.
No, but it was just it was a transitional period. So I went to Boston immediately and I met Marcel Mesulam, which is the pioneer in behavioral medicine.
Yeah.
Cognitive neurology. And his wife, Sandra Weintraub, a very important neuropsychologist.
Oh, she's as well.
Yes.
I didn't know.
So I worked with them as their research assistant for 2 years while I was studying for my exams, because they told me that it was a dream to do my specialty in Boston. It was very competitive. So I collected some referrals, learned about everything, and then I was so happy to be in this field. And then this is how I started my training.
But you didn't study that in Turkey?
No. In Turkey, I
it's
did
general
medicine, and I did all my specialty in United States.
Yeah. Yeah.
Yes.
And then,
And
yeah, okay,
fellowship.
let's talk about it because 30 years ago, I'm sure that you had much less information, less research studies, and kind of confused, I guess.
It was. And then I remember so vividly, it was 1996, the first medicine, donepezil, came out, just FDA approved. And I cannot tell you how happy we were that there was something we could give it to people. Yes, it was just, it was not cure. There's still no cure.
Sure.
Yes, it is a slowing down of disease, which I will talk about why it is important.
Sure.
It was new era. When I first arrived in Boston, I did some studies for encephalopathy and HIV dementia. You can imagine.
HIV dementia.
HIV dementia.
Wow. What's that?
HIV really goes in the brain and causes a very profound dementia, but we
Wow.
don't even see it anymore. Why? Because we are able to treat HIV. So,
Oh, yeah, okay. The cause, the root you were
Exactly
able to
so.
treat, yeah.
so anyway, we still have much more progress to make because I think there's still much to know, but every day we're learning something. But I was just looking at the serum biomarkers that we can get right now. It took us 100 plus years to be able to achieve a blood test.
My program, Ayık Kafa, is around subject matters that people need to really pay attention their lifestyle, whether in addiction or pollution or hormones, whatever, because there's only a minority that are able to reach to these doctors or to the supplements or the informations, especially because they're in English, most of them. I decided that, I want to spread the message, the information. But still today, I see very clearly there are like two opposite beliefs in hormone replacement therapy, in Alzheimer's disease, how to treat it or what's causing it, in many other things as well. So what I saw that, these doctors who are specialized, whether for heart or for brain, for kidney, for whatever, they don't look to the whole big picture. They just focus to that one organ, which my understanding and what I heard, how you're describing what's causing it, even though you're not saying that, functional medicine and it has to be, and we can stop it, reverse it, whatnot, and I'm going to come to that. What I see is that if the person pays attention the way they live, pay attention to the toxins, pay attention to all the new researches that, microplastics in your blood that can go to your brain, oral hygiene that can go to your heart, then to your brain, the heavy metals. I know it's difficult to live like that, but at least the knowledge and the awareness is so important. People
Very
make fun of me, but
No.
the alternative is horrible.
Exactly so.
So I see that you believe in both, even though you don't believe that you can reverse the Alzheimer. But from 30 years ago, the medication, did you guys ever thought that lifestyle has an effect on it?
I did, because as a neurologist, for me, the brain health is very much related to below the neck. Is that right? It's your gut. It is your vascular health. It's your abdominal fat. It's your diabetes, everything. So it's very important for me to communicate with my patients saying, please do not gain weight. Please keep your cholesterol, your insulin resistance, hemoglobin A1C within normal levels. Don't smoke. Don't drink excessively. Pay attention to being active, exercise, be social, try to keep your brain active. So, again, I think it's very much of a lifestyle.
Mindy Pels was here and she was explaining how she's creating new neurons in her brain. And she gave an example like she's in a country that she doesn't understand the language, she doesn't know the streets, but she has to figure out how to move from one part to the other so that every new learning would fuel the brain in a way.
The most common question is, should I do Sudoku every day? First of all, I hate Sudoku.
Me too. I never touched it.
I never played any games. So for me, for example, I'm just right now brushing my Italian. So just it's something that I always wanted to do. And I realized that it was so dusty. So, learning, curiosity, I think is very important.
Yeah, I think intellectual capacity of someone have a huge effect on how their brain works. Because, even me like speaking Turkish, then flipping to English, then flipping back to Turkish and trying to figure out these scientific words probably makes my brain works a lot. I heard you saying this hemoglobin A1C levels, insulin levels. But here's the thing, what I saw. Normal doctors, you go to them, and if let's say I think it's the hemoglobin A1C level, yeah, it's like 5, 6, well,
Exactly.
yeah. So normally it's hoped to be under 5. Over here, it's like 6.5, and they were like, oh, you're okay. What are they waiting, like to be 10, and now you're full-blown diabetic? So when you tell to your patients, probably, I'm assuming, if they have an internalist or whatever other doctor who doesn't believe or curious about functional medicine approach, what you're telling them, if you don't say specifically, hey, I want it lower than 5.5. 5 is a very idealistic number, probably. 5.5. If you don't say that, and if you just say like, keep it low, and the other doctor sees the 6.5, and he says, okay, then you're not still able to cross the message.
I know. This is why I try to work with the primary care physicians we are in the same, just the length. It's very important. If the patient does not have a good primary care physician, ask them to change it. Saying, I see so many people with LDL just being very high. Okay, so again, high LDL treatment is controversial also.
I know.
But still, again, pay attention to your diet. Do this, do that. Check it again in 3, just, do you have family history? Did anything happen to you? Did you have any heart disease? Did you have any stroke? Is that right? These are very important. I mean, I see so many people who have had 3 strokes in their brain and they have a very high level LDL and they are not being treated. This is neglect, nothing else. So
it's neglect because the way that they're approaching, like I really like Dr. Daniel Amen's sayings. He says like, you don't need to have a concussion to have a problem on your brain. And over here, they expect you to faint, whatever. And since I listened to a couple of training sessions of his actually and read the book, I stopped jumping head down to the water. He says like over and over and over, hitting your brain onto a rather hard surface, it's going to somehow make a problem.
Of course.
But when I say these to people, they really think that I'm weird, in simple words.
Well, at least we know at football player what happens. So
yeah.
I don't know about the diving, to be honest with you. But, again, there is very important and very scientific data about repetitive head traumas.
How do you feel about these new treatments? First of all, I wouldn't be able to memorize all these new very weird names.
Lecanemab and donanemab. They are very hard to pronounce.
It's kind of like, I don't even know how they came up with these words because it means kind of nothing. But also I watched that they're able to, with ultrasound to the brain, able to enlarge the veins and then put the infusion inside.
Increase the likelihood of medicine to go into the brain.
Exactly. But they saw on the imagings that the amyloid plaques are reducing.
Exactly so. So the first lecanemab, which was first FDA approved last year, so they are anti-amyloid medications and they are given by infusion. Lecanemab is given every 2 weeks. So the idea is very much of a reduce the amyloid accumulation in the brain so that we can stop the cascade of amyloid tau and then the neurodegeneration pathway. Is that right? So unfortunately, to my knowledge, 2 deaths have been reported. So to death. So there is a amyloid-related imaging abnormalities, ARIA, just as a side effect, which causes either edema versus hemorrhage in the brain.
I read that, yeah.
That's right. So it's almost 17-18% for lecanemab. And then the reason it was FDA approved was that it slowed down the cognitive loss by 25% in 18 months, which means 4 to 5 months of slowing
just
disease. Exactly so.
Not
and then
more.
donanemab came up just this year. Its slowing was 35%, a little bit better, but the ARIA risk, the hemorrhage, and then the edema risk is almost 30%. So, and ApoE4 allele people were more likely to to bleed. And then also any patient who was receiving anticoagulation, blood thinning medication, were likely to bleed. So another dilemma. So first, as you said, this kind of slowing, is it worth taking the risk?
Yeah.
Isn't it? Many elderly are on anticoagulation. So they are going to be excluded from this kind of treatment. And then the other ApoE4 allele are more likely to bleed. So they are also being in warning criteria. And then that's also is a dilemma because we know that if you have ApoE4, you're more likely to have Alzheimer's disease and you're more likely to start the disease in a much earlier age. So then if I also exclude these people too,
who are you going to give these?
Exactly so.
It seems like, there's a huge
pressure.
There's the, money, the fundings.
It's almost 20 years that donepezil was approved by FDA in 1996. The galantamine and ivastigmine came shortly after. So late 90s. So 24, 25 years, we haven't had any treatment options. I think this was the very much of a very important criteria. After the first anti-amyloid treatment was approved, many people left FDA, all the members, because they were very against it. So,
what do you use?
Well, right now we can't use it in Turkey because it was not also approved by the European community. So it's not available in Europe. It's not available in Turkey.
But it seems also it's dangerous and it's very, very narrow.
Exactly so.
People that
and also it is a very costly treatment because as initial diagnosis you have to be in mild cognitive impairment versus in very early Alzheimer's disease, which has to be confirmed by biomarkers, either by CSF or PET amyloid and PET tau. So which are still, PET amyloid is FDA approved but not covered by insurance. It's almost $4,000 in the United States. Same thing for PET tau. And then you have to have infusion for lecanemab every 2 weeks, for donanemab once a month. You have to go to an infusion center. And then the first 3 months, you have to have MRI after each infusion. So it's very costly. The medication itself is almost $30,000, $27,000 to $32,000. So, and then in additional expenses with infusion centers, MRI and such, and PET amyloid or such. So I'm not sure that it's worth the risk.
Yeah, it's financial and also
it's a burden.
Physical risk. You're talking about all these things that happen into the brain.
Because there are very few
So what is working then? What type of medications? Because I know that you use some meds. It's from the past.
Right now, I tell my patients that I'm juicing up your brain.
Juicing up the brain.
Exactly.
That's nice.
So I'm giving acetylcholine.
So I can take it as well. So I'll be smarter. No, is it too much? It would be too much. No comment.
No comment.
But it's not like the supplement acetylcholine. It's like I was just joking.
It's not a supplement, but then maybe just, compared to supplement, at least you're taking a real medicine because there's no FDA regulations with the supplements. So what? We don't know what's in them. So that's another controversial topic. But so we are giving acetylcholine to patients, and acetylcholine is a very important neurotransmitter, especially for the memory network, creating a more synaptic communication so that they can remember better. And it can be an activating, especially when patients are in mild cognitive impairment state. Before converting to Alzheimer's disease, it can activate the brain. Some people
like a bit
feel better.
Effect.
Exactly so. Feel better, remember better, feel more awake, more energetic.
It's almost like they're hyper.
Exactly so.
It's hyper.
It can be. But I tell people that I'm not giving this medication to make you feel better. I would like to keep you as steady as possible. Or without medication, you're going to go down like this. With medication, I'm going to slow down the progression. I think educating the patient and the family is very important because a lot of the times this is doing nothing for me. I don't want to take it. So, and I say, no, it is not supposed to do anything. You're not supposed to have a tangible effect. But I'm trying to slow down the disease. That's why we're giving the medication.
Are they different dose that you can change up or down?
Exactly so. Unfortunately, because they are cholinergic, they increase all the solutions in the body. So
What does that mean?
means that increases all the gastric enzymes. So then the nausea, vomiting, diarrhea,
And also some
bloating,
heart
lowers the pulse.
pulse, yeah.
So you can't give it to syncopal patients. These are the most common side effects, mainly GI and the bradycardia. So you have to be very careful. And so this is why you start gentle, get the body to get used to the medication and increase the dose. But there is some dose dependent effect, but you don't want to give it then more than what's recommended, then you run into more side effects.
Let's now touch base on Schneiber, I think, with her support. Lisa Masconi is one of the PhD over there. Is really, I read her books. She's relating it, of course, like what I saw in this industry, whatever people are doing their studies and researches, they're kind of saying, okay, that's causing. So let's not just say that that's causing, but she's really, couple of things she's saying. What you said, that people are living longer. Therefore, we kind of don't know what to do with people getting older. It's just now it's showing its face that, oh my God, we're not dying at 50. What are we going to do after? For women, they say out of 3 Alzheimer patients, 2 of them are women.
Exactly.
And then she also relates that to the menopause, the changes in the hormones, therefore the brain, and that women carries more burden and more depression. So therefore they're more affected, their brain. What's your take on this?
I really believe that estrogen has a very protective effect on the brain, and that with complete, especially in the perimenopausal state, with the lack of estrogen, I think brain is like, what's happening here? I'm so used to this, and why I'm not getting it anymore. So there's some studies, many over the years. I'm very interested in women and Alzheimer's disease. I've looked at a lot of data.
I even thought to get into their study. I reached out to them because they kind of take the fMRI, whatever, all these brain imagings,
Exactly.
and they year after year they compare where the brain
So
is.
estrogen has effect on the inflammation. Estrogen has effect on neuroplasticity. Estrogen has effect on the brain health. All of it. It's very conflicting. First of all, still remains to be conflicted because Women Health Initiative, which is a very large study, which again said no, HRT increases the risk of dementia. Don't give it. So smaller, just studies, and then other studies saying no, you have to do it. But I think Nina Masconi and others, what they are saying is that there is a little window treatment period. That window, perimenopausal and menopausal. If you grab the woman in that state, you can be very helpful.
Okay,
But
not after,
not
just
after.
Gradually,
Exactly so.
gradually
It's almost like
balancing what's missing.
what they were saying before, it was almost a 5-year window period, but now I don't know that 5 years.
5 year, like stop in 5 years?
No, 5-year perimenopausal and menopausal 5 when it is happening.
Okay.
So for example, we know that hot flashes, almost like a warning sign. Women who had hot flashes are more likely to have Alzheimer's disease. Is it because this woman feel the oxygen lack of more and it affects their brain more? I don't know.
It's like having a high fever in a way.
Exactly so. But my question as a woman is always, it is very confusing, when are we perimenopausal? So what's menopause? Menopause is when
It seems like it's
finally
one
stop.
day.
Exactly
they say.
so. Is it just, it's defining it. So, and getting hormonal levels, how much they tell us. Hormonal levels could be completely normal, but you can still have perimenopausal symptoms. So is that, where I'm going to say, oh no, your hormonal levels are great, so just forget about it. So again, there's many confusing information about what is perimenopausal, what's menopause. Second, are we going to give only estrogen? We can only give only estrogen to people who doesn't have a uterus. If they have uterus, we have to definitely give progesterone because it has to protect the uterus from the estrogen effect. And if we are going to give progesterone, is it going to be natural versus synthetic? And they are saying natural has to be given other than synthetic.
Sure.
Are we going to give cyclical versus continuous? Are we going to give oral versus transdermal? So much that we need to learn. For example, there's a very recent study that came from Europe looking at HRT in menopausal women with ApoE4 carriers. And the study showed that their verbal memory much improved and their amygdala value much improved. So volume improved, cognitive test improved. Maybe we have to detect this a woman with the ApoE4 allele.
I heard about a Turkish doctor who gave to his former wife that was declining estrogen, and the woman perked up. Even though it was like post menopause.
But what they are saying is that after the age of 65, especially, you give HRT more than 10 years, then you definitely increase the risk. And then also the duration of the HRT. If you give less than 1 year, it doesn't mean anything. They are saying that you have to use at least 10 years to be able to see the effect.
I don't understand doctors here because I speak to many, many doctors in the US, and most of these researches are happening there. Over here, what I hear all the time, like they give women bioidentical or not hormone replacement therapy for a couple of years and they stop. And I'm like, that makes no sense because the new approach, what I'm seeing, I have a friend in New York, a Turkish, but she doesn't speak Turkish. Piraye, I forgot her last name, but she's a PhD and she has a biotech company. She did researches on ovarian health. And saying that, ovarian health is so important and directly related to aging for women. And they're trying to figure out a way to keep the ovaries healthy and push the menopause, not like an unhealthy push, more so starting from the puberty onward. When I hear here they don't want to give anything to women, I'm like, oh my God, I want to hit my head to the walls. But, everybody has their own approach. So what you're saying is, even though they're researchers, they're still on a research base and they're still conflicted. Therefore, you as a classical trained medical doctor, do not harm first. Therefore, until you have the full-on data that you can rely on, you're still watching every outcome and seeing based on the patients coming to you what's going to help.
Exactly so.
So you're not just saying, okay, I'm giving estrogen because you need, you just look to the whole picture.
I think it's very important.
So what do you think then about reversing Alzheimer? Because it's now, it's everywhere. There are a couple of books, there are researchers and neurologists. It's not like, like a grocery shop owner is saying it. Very esteemed neurologists are saying it.
I know, but I think as a neurologist and as someone who also knows about what neurodegenerative disease is and how it works and how it starts, how it progresses, the neuropathology, I do not know that you can reverse Alzheimer's disease. I don't think so, because I think it's a very progressive disease, and unless we come up with a specific treatment, I don't know that you can reverse right now. We don't have the technology. We don't have the knowledge, first of all, to reverse Alzheimer's disease. What could happen is that, someone has Alzheimer's disease, has a terrible diet, sugar is everywhere, not doing anything, socially isolated, not moving, not exercising or such. By means of modification of environmental factors, you can make someone feel better. And treating depression, again, treating insomnia, is that right? Making them active. I tell people, just again, the older people are very habitual. They are very stubborn. They don't want to change their lifestyle. And if you have dementia, you're more likely to be much more ritualistic because you don't like novelty. So they are not interested in changing anything because change creates anxiety. Change creates stress. So I tell people, just go down and just walk for half an hour for me. So do something. Again, do you like watching just the TV? At least watch some documentaries, learn something, listen to music.
So based on what you're saying, I feel like you're thinking their regimen is very strict in order to make these bits of changes.
Exactly so. They really thrive in very much of a strict environment. They like the sameness because that's not challenging. Any new novelty is very confusing. So I tell them to have a very ritualistic style, but then add do walking, some kind of cognitive stimulation to that regimen without really rocking the boat.
Like in many things, especially when it comes to health, unless you're very knowledgeable and at least you're aware you're not doing the right thing, but it's only just like once in a while, but normally you have a nice routine. I see other people, they slip away from that positive, good, I need to do this. They're just so easy. They run maybe, let's say, 2 days, then they just like they're done. They change their diet for a couple of days or a couple of weeks, then suddenly you see that they're going back to how they live. Humans are interesting unless they're
complex.
Yeah, they are. Unless they're like me, that I'm curious about this healthy way of living. Not that I'm not always restricting myself, but I'm very curious. It's just like it makes me feel good and almost special about following a certain positive lifestyle. But I think that the comfort for people is sometimes very, very negative, actually. This Mindy says this: comfort is the worst thing to make one age faster.
I totally agree.
Comfortable is like we're so comfortable, we don't leave the couch, we have the remote control, we watch a Netflix series like sit down and never
Typical
leave.
American lifestyle.
We order food, it comes, you don't do anything, it's comfort. You're going to die faster and get old faster.
Exactly so. Lifestyle is very much of your personality. I very much think that it's about self-respect. I really respect my body.
Mm-hmm.
And then I want to really take care of it because, I really want to age successfully. So to me, it's very important as a person. Forget about being a doctor. But I don't know how many people are aware. Yesterday, I saw a patient. He told me he has never been in a checkup. He's 75 years old.
Oh, wow.
I said to him, do you take your car for service every year? Of course, he said, I do. I said, you take your car for service every year, but you don't check yourself every year. So I am unable to understand. You don't have as much value as your car, your body? He paused. He said, you're right. I said, well, so you're going to the doctor tomorrow. So it's amazing.
Let's take a random person in your practice. They're kind of not too bad. Not at the very, very beginning, but let's say a couple of years now that they're struggling. With the medication that you give, acetylcholine, you said. Plus, if they do an extreme life change to make suddenly like detox themselves from heavy metal if they have mold, whatever they have, wouldn't you see not just the flat line, but go up? Improvement.
But improvement, so that's what I think.
Improvement. Okay, they're using the word a bit flashy for the headlines.
Exactly.
All right.
Okay, improvement doesn't mean that I am reversing Alzheimer's disease. I am just seeing improvement in their cognitive status.
Okay, but that's good enough.
Absolutely so.
So that's.
But that's the reason I give the medication too, and also giving the medication has an effect on later in the disease. Giving acetylcholine diminishes the behavioral symptoms of hallucination, paranoia, delusions.
Oh, wow.
So, and that are the most difficult to take care of by the caregiver. When someone is completely delusional, paranoid, you can take care of them at home. That puts the patient in a nursing home. That's another reason I give the medication, to be able to take a little bit burden out of the caregiver. To me, it's very important.
Yeah. We focus to the regular Alzheimer. We just spoke a lot. And I guess besides the gene types, also they call it diabetes 3 now for Alzheimer's disease. So they very much relate to diabetes and the way of eating.
Very much.
Unfortunately.
Because insulin has an incredible effect in the brain. Again, it's another very important modulator for everything. So again, if we ruin our insulin levels, that's going to have a significant effect. So if you have diabetes, it affects multiple organs. Is that right? So it's going to affect your kidney, it's going to affect your eyes, it's going to affect your autonomic system. But look at the obesity in the world, not only in adults, in childhood, the kind of food they eat. So I tell people to lose weight, not to eat much.
Exactly. I think these intermittent fastings helps to that. because it just restricts
I'm
people.
very into it.
Typical Alzheimer is more of a lifestyle caused a bit.
Mm-hmm.
If you have a tendency like addiction, like why I did have the addiction and not my sister. Obviously, there were some genes, maybe some low dopamine in my brain or something. It cannot be like just one gene, but it switched. But there are the other ones.
Frontotemporal dementia.
Yeah, it's like that or the Lewy body. These are they lifestyle related or it's a different type?
I think that they are no different than Alzheimer's disease in terms of what happens, in the sense that, yes, in FTD, it's the tau and other proteins. In Lewy body, it's the Lewy body accumulation or such. I think it's a similar pathology and affects in a different way, different either cognitive domain or different pathways or different part of the brain, but causing similar symptoms. In Alzheimer's disease, it's the short-term memory. In Lewy body, it's more just, behavioral. It's Parkinson plus. It starts with a cognitive decline, but affect more executive and visuospatial functions, not the memory. In frontotemporal dementias, it's more a personality change.
Yeah, that's very interesting.
I know. It's your judgment. It's your insight.
Empathy.
It's your empathy, very much so.
Compulsive eatings and stuff like that.
Exactly so. So it's fascinating types of dementias.
Do they have any treatment? It seems like they kind of decline very quickly and they die within the 10 year, they say.
Well, Alzheimer, usually prognosis is 10. FTD is definitely shorter. And Lewy body depends on treatment, usually because they have a very significant Parkinsonism from the beginning, the risk of falls and difficulty with the swallowing causing aspiration. So they are more likely to die from the side effects of the Parkinsonism.
No medication, no treatment.
Oh, we treat Lewy body with Alzheimer's disease medications. FTD does not respond to especially acetylcholine. If anything, it makes it worse. People become much more aggressive. So other than SSRI, and now there's some new treatment options coming up. Methylene blue has been
I was just going to come to that. All right.
In tau pathology.
I've been reading methylene blue, and actually transcranial magnetic stimulation is helping, they say, when it's a low cognition level.
Very much so.
Do you use methylene blue?
No.
Why not?
No, because it caused significant side effects in initial trials in FTD. So
like which one? The serotonin syndrome. But they say like it's only 1 or 2 cases.
I know, but again, the clinical trials when something happens and they freak out and then they stop. It was stopped abruptly.
Yeah.
The UCSF has significant work on FTD, just Jeff Cummings and group. So anyway, I monitor and very much read everything
I'm sure you do. You came with all these study reports over there. And there's this very interesting town in Colombia.
Exactly.
That almost half of the population has
the genetic form Alzheimer's disease. It was a local doctor, a Colombian neurologist whom I met in one of the Alzheimer's disease conferences. Such a beautiful man. He was, again, very curious, extremely beyond the window person, which we like. Is that right? So he said, what's happening here? Within the family marriage, like Turkey. So the whole village marries each other, all the relatives. So then start seeing this very peculiar, starting with the neuropsychiatric symptoms, Alzheimer's disease, and one after another. Then in one of the Alzheimer's disease meetings, approaches one of my colleagues, Ken Kosik, who is now in California, who was doing basic research, saying, I'm seeing these patients. And Ken becomes very interesting. I remember this so well. And starts going to Colombia, starts getting old blood samples. And then that's why we find out that, they have autosomal dominant Alzheimer's disease.
Autosomal dominant.
Exactly so.
They were saying like really weird stuff, like there's this one son of that guy explaining that one day he saw his father trying to wear a shirt to his legs like a pant. So like it's not like a typical
It starts more with the behavioral symptoms. That's why it was very confusing in the beginning. They thought these people were either schizophrenic or paranoid or such. Starts with the neuropsychiatric symptoms and then goes on to cognitive decline. So there are 3 preceding 1, preceding 2, and EPP. These are 3 genes that are autosomally dominantly inherited, so your risk is 50%. They were very interesting for us to study. So for a long time, these anti-amyloid treatment, when they failed, the researchers were saying the only reason they failed because we give this medication so late. When the pathology is already consumed the whole brain, we are not being helpful. So people said, okay, you know what? These are genetically determined
and they
to
were
have
all willing
Alzheimer's
to get
disease
into the
patients.
study.
So let's give it to them. Let's see what happens if your theory is correct. The first trial has been abysmal, failed. So now they are doing another trial. I had 3, 4. It's called Diane, dominantly inherited Alzheimer's disease trial. They used another anti-amyloid. Now they're trying with the lecanemab. Again, we are waiting for the results to see whether they are genetically determined. So if the mother has it, we test all the children. We find the gene in 50% of them, and then we take the ones that carries the gene, and then just we give them the anti-amyloid treatment. First, they were flying to Texas. You can imagine how costly that treatment was, the trial was. Now they are just being given locally, but we will see. So they're very interesting, just
it's
population.
probably a good hope for you guys. At least there's a willing population because they know they're going to get it.
Exactly.
So they
same thing with the Down syndrome too,
It's a sad disease.
Very.
It's just one of these diseases that people are so helpless. And you even said that you wouldn't test yourself.
I wouldn't.
And my dear friend Susan Blank also, she says, I would do everything right, but I wouldn't want to know.
That's what I am doing right now.
Yeah.
I am trying to do everything the way it's supposed to be.
Let's look to the positive sides a little bit. So you said that there's some blood markers that you guys can see, but it's still seeing, then you don't want to see it, correct?
Well, there are people who wants to know. There are people who doesn't want to know. I don't want to know, but then I have many patients said to me, I would like to get a CSF biomarker. I want to know. If you have family history, of course you have an increased risk. If you have more than one family member, your risk increases. So I want to know because I want to plan my world ahead around it, which I have tremendous respect. So, again, yes, now many serum biomarkers, beta amyloid is available. I think it's $300-400 when I went to Boston in June. That's what it was.
And not many doctors can interpret them.
Exactly. So 2 centers are doing it, the beta amyloid one. Now the phosphorylated tau 2 came up too, which I think has a good sensitivity and specificity. And then there are many biomarkers, neuroinflammation biomarkers, cytokines, many, which are still in the developmental range, which I think is going to be very helpful because prior to the trials, getting a CSF, getting a lumbar puncture versus getting a PET amyloid, which is very expensive. These are very either invasive. Not many people want to have a lumbar puncture. I understand them. Versus PET amyloid, which is very effective. I mean, you're going to get a blood test and you're going to know. I think they're going to be very helpful even for clinical trials.
Let's end this program with a hopeful talk. What do we tell people so that they either delay or do not have it in the future?
What can we do to prevent?
Yeah, exactly. Like from starting, what age? What do we need to pay attention?
I think from the earlier age, just education is very important. Especially, I think one of the reasons women have more Alzheimer's disease is that, remember, our older generation didn't
lack of education.
Of course, it was very important.
Or shorter education.
Exactly so. So education from childhood. And then middle age, I think it's about, again, weight control. Make sure your hearings are okay. Hearing loss, again, sensory loss is very important in prevention. I ask everybody to go to their eye doctor, make sure they see it very well because seeing and hearing is very important for our cognitive stimulation, isn't it? Either we hear or see. That's how we stimulate our brain. Definitely no hypertension. They did a hypertensive study looking at people who are at risk giving antihypertensive. They halted the trial in the middle. It was so effective. They did not want to continue. So again, hypertension is very important. Paying attention to your hemoglobin A1C, insulin resistance, lipid profile, smoking, alcohol, smoking especially, and alcohol, excessive alcohol intake, treating your depression if you have it, high stress, and insomnia.
Insomnia, it seems like so important.
Sleep quality is so important because the resolution of memory happens during sleep. Sleep is
such as also sleep apnea and so on and so forth. They say to
Very
keep
much.
cutting the oxygen.
Exactly so.
And I think I would like to add also try to eat clean, not only look to the level.
Eat Mediterranean diet, but eat clean.
Clean
exactly
meaning
so.
like, try to organic, try to stay away from the pesticides
Exactly
and
so.
heavy metals and so on.
Any plastics, and to me, the most important I forgot is physical exercise.
Okay.
Very important. You have to exercise.
So if we follow that, then we really reduce
40% reduction by means of, talking about what we just talked about. 60% still unknown. I'm sure, of course, as you know, there's genetic risk factors and risk genes and all that, but 40% is not a small number.
The message should be that it's, first of all, never too late to take your life back in your hand and try to do the healthy thing. And instead of just being afraid and do nothing, just be afraid and do something.
Exactly so.
Thank you so much. That was a wonderful recording for me because I learned a lot. It was an interesting thing to speak in English, but we made it.
We made it.
Thank you so much for your presence. And I hope that people would listen to this episode and understand the ins and outs.
Thank you.